Dr. Som, we can begin now.
Yeah. So shall I start?
You start.
Hello?
Madam,
Yeah.
can you stop the share for a while, ma'am?
Sir, we can take control. If you want, I can change the script slide.
Yeah. Doctor, will you share the screen, no? Madam, for this thing, madam's profile?
Okay. Shall I share the screen? Okay,
Yes,
I'll
yes.
share the
You have to
screen.
share the screen.
Yeah. Can you see the screen? Hello?
Yeah, we are able to see the screen.
Okay. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you for joining today's webinar. I request all the participants to post their questions in the comment box so that we can address at the closing of the webinar. And good evening, Dr. Madhavi, madam. Thank you for joining today's webinar. It's always an honor to introduce you, ma'am. Dr. Madhavi, she have computer medicine and DGO, FMS, FRM, and she's a senior consultant and obstetric gynecologist as well as a laparoscopy surgeon practicing in West Maratpalli, Secunderabad. And she has about 22 years of practice in consulting experience, and also she is a consultant at Geeta Multi Specialty Hospital, West Maratpalli, Secunderabad, and she is a consultant at Basant Sahane Hospital, consultant and also consultant at Yashoda Hospital, Secunderabad. Her field of interest is high risk pregnancies, vaginal surgeries, infertility, and laparoscopy surgeries. She has done her fellowship in laparoscopy from World Laparoscopy Hospital, New Delhi, accredited to VATS. And she has strong desire to learn and consistently update her knowledge in all fields of obs and gynecology. And she has given her many guest lectures on adolescent girls, obs emergencies, cervical cancer vaccine, and all the experts of panel for cervical cancer vaccine. And she is regularly conducts camps for anemia, thyroid screening, BMI, osteoporosis, and screening for breast tumors. She has conducted many virtual CMEs during the pandemic on GDM, emergency contraception, nutrition in pregnancy, and others. And she regularly attends CMA programs, workshops, and conferences in India and abroad to keep abreast of the latest development. And also, she is also in the sub committee for the health for the All India Industrial Exhibition and a member of governing body of Alan Gupta Memorial Health Center, Hyderabad. She is a life member of Foxy, IMA, and IGE. With this, I welcome you, ma'am, for today's webinar. And we have a short AV on Shield Connect launch, which is a digital platform. I request your permission to play the AV. Ma'am, we can't hear you. You're on mute.
Can you hear me? Hello?
Yes, ma'am. Yeah, it's fine.
Thank you. Thank you, Dr. Someshwar. Thank you for your kind introduction. And you can proceed with the digital presentation which you have, Dr. Someshwar.
Yeah, thank you, ma'am. Yeah, KVK, can you please play the Shield Connect launch?
So I'm just opening the Shield Connect page.
Okay. Shield Connects is a digital platform to connect all the doctors at one place with the latest scientific literature, as well as with the webinars and the blogs. And Shield Connect continuously not only going with the innovations with science, as well as with the updating every scientific literature to possibly reaching to the all the doctors in the fraternity of gynecology, infertility, as well as to the patients. Yeah. With this, we thank you, ma'am, for giving us your valuable time. I request all the delegates to please go through this link. You will find all the past webinars and upcoming webinars for the all the doctors. Yeah. Thank you, ma'am. Over to you.
Thank you, Dr. Someshwar. Namaskar, everyone. At the outset, I wish you all a very, very happy, prosperous, and a healthy New Year 2021. I thank the organizer for giving me this opportunity to talk on this a very complex subject, multifaceted approach to PCOS. PCOS, I would be going around with the overview. PCOS affects almost 6 to 15% of women of reproductive age group. And of the 80% of the adult hyperandrogenism is due to PCOS. And the prevalence, according to NIH criteria and Rotterdam, that varies 6.1% to 10%. Till now, we haven't had any data on the adolescents. Now, let me tell you about the history. What says, which was discovered in 1935 by Steen Leventhal, which was thought to be characterized by oligomenorrhea, hirsutism, polycystic ovaries. And then they had a clinically, they were correlating as to bilateral wedge resection of enlarged ovaries. So our practitioners or the physicians and the surgeons, they kept on doing the wedge resection of the ovary. And then it was after 30 years, we discovered as to it had a disorder which is called as hyperinsulinism. And now with the current status, what it says, it is basically a unique disorder of insulin action as well as defect in the insulin secretion, and together these abnormalities conferred a substantially increased risk of glucose intolerance. Now, epidemiology, one of the most common disorder which is affecting women of the reproductive age group, and mainly it is the anovulatory infertility in the reproductive age group. Almost 8 to 11% of the women suffer from this. Anovulatory infertility contributes to almost about 70 to 80% in PCOS. Indians have the highest prevalence rate in the world, almost as good as 41%. I think this is a not a good thing we should be happy about. Now, PCOS, an epidemic in India, 41%, which contributes to almost 117 million patients and rising. So 1 in every 5th woman is having PCOS. Main clinical and metabolic manifestations of polycystic ovary syndrome, according to woman's stage of life, clinical manifestation of PCOS appear in adolescence. So initially there is fetal programming, and which could be like IUGR, SGA, and then there is insulin resistance, adipose tissue dysfunction, excessive postnatal catch-up weight gain, premature adrenarche, premature puberty, and menarche, which, if it is not really monitored, it leads into weight excess, visceral adiposity, irregular menses, acne, seborrhea, hyperandrogenism. This further contributes to obesity in the reproductive age group women, carbohydrate intolerance, dyslipidemia, infertility, and pregnancy complications. Once the woman finishes her childbearing, she enters into her menopause. Then we see the complications like type 2 diabetes, dyslipidemia, cardiovascular, disease, arterial hypertension, and endometrial cancers. The spectrum of PCOS from child to menopause, biochemically, what it says is that predisposing factors are like the genetic factors, in utero programming. The biochemical markers are like increased AMH. Clinically, they present with the premature adrenarche, hyperandrogenism, increased GnRH, increased AMH levels, ovarian volumes, and hyperinsulinemia. In reproductive age group, we come across women with complaints of irregular cycles, hyperandrogenism, subfertility, infertility, and increased AMH, antral follicle counts, and ovarian volumes. Postmenopausal women, they have increased prevalence of hypertension, increased triglycerides, and they are at increased risk of cardiometabolic phenomena, glucose intolerance, adiposity, and hypertension. The natural history of PCOS, premature adrenarche gives rise to clinical hyperandrogenism, infertility, and irregular menses, which further contributes to, if it is not regulated, they are at risk factor for diabetes mellitus, dyslipidemia, high blood pressure, and which these cases further progress to cardiovascular diseases, endometrial cancers, breast cancers. Now, we come across how the maternal hyperandrogenism has impact on the fetal life. The baby is born with IUGR, low neonatal weight, adolescence, childbearing, menopause, and postmenopausal. So, in all these, throughout the journey of the woman, the genetic and environmental factors play a major role. Diagnosis of PCOS. Criteria for diagnosis, mainly hyperandrogenism, oligomenorrhea, polycystic ovaries. Now, this is a beautiful flow chart which tells us about patient meets clinical criteria of PCOS. If yes, then you have to rule some of the pregnancy tests, measure the serum TSH, prolactin, hydroxyprogesterone to rule out pregnancy, thyroid dysfunction, hyperprolactinemia, and non-classical congenital adrenal hyperplasia. If no, then we need to consider serum androgen tests and ovarian ultrasonography to confirm. If any abnormal result is seen, if findings meet the criteria, again we need to rule out with the thyroid dysfunction. And if these are normal, then we need to check with the low birth weight, eating disorders, or excessive exercise, measure the LH, FSH, and estradiols to rule out hypothalamic hypomenorrhea. Hot flushes and urogenital symptoms, measure serum FSH, estradiol to rule out primary ovarian insufficiency. Severe virilization, changes in clitoromegaly, rapid onset, measure the total testosterone and DHEAS, then perform ultrasonography of ovaries and CT or MRI of the adrenals to rule out androgen secreting tumors. If the woman presents with buffalo hump, purple stria, hypertension, then you have to measure some of the salivary, urinary cortisol levels, or perform the dexamethasone suppression test to rule out Cushing's syndrome. Changes in hat or the size of the morphology of the woman is increasing, which is known by increase in the hat or increase in the glove size, protruding jaw, impaired vision. Then measure insulin-like growth factors 1 to rule out acromegaly. If these levels appear to be normal, then diagnosis is confirmed. Proceed to screening, like check the blood pressure, perform the lipid panel, and 2-hour OGTT evaluate for signs and symptoms of obstructive sleep apnea and overweight patients for depression. Now, our whole aim, as we said, from early adolescence, late adolescence, adult fertile age, the girl presents with early menarche, regular menses, weight gain, hirsutism. These are the common symptoms which she presents with, which in later adult fertile age group, androgenism is manifested as hirsutism, acne, alopecia, hyperandrogenemia, and irregular menses, particularly oligomenorrhea or amenorrhea, infertility, overweight, or obesity. Features of metabolic syndrome and type diabetes mellitus, PCOS is seen on ultrasonography. So this is the normal, this is the journey of the PCOS woman, which is recognized, which has a fetal intrauterine programming and up to the menopausal age. There are different phenotypes of PCOS: hyperandrogenism, not obese, and non-insulin resistance. They progress further into extreme obesity, insulin resistance, and hyperandrogenemia. The different phenotypes are A, B, C, D, E, F, and this the A to F, they are at risk of metabolic disorders, hyperandrogenism, hirsutism, oligo to anovulation, and hyperinsulinemia, whereas G, H, I, they have mainly the metabolic disorders, hyperinsulinemia, the percentage is almost 3 to 6%. Now, what is the PCO appearance, approach, and form? In what all ways it is manifested? The hyperandrogenism, acne, hirsutism, is dealt by the dermatologist and the endocrinologist because the woman reaches with the skin lesions, crops of acne and the pigmentation on the nape of the neck, with lot of acne on the arms, back, nape of the neck, cheek, jawline in a V pattern. So she reaches the dermatologist and endocrinologist. Insulin resistance, hyperinsulinemia, type 2 diabetes mellitus is dealt by the diabetologist, endocrinologist. Worsening follicles and quality and unsuccessful ART, it is dealt by the fertility specialist. Now, with the menstrual disturbances and the anovulation and fertility problems, she approaches a gynecologist. Because of her obesity and the psychological symptoms with body shaming and depressive moods, the psychological problems and depression is dealt by the psychologist. So PCOS has to be dealt in a multi-pronged approach. Now, what is the epigenetic risk for PCOS? Perinatal infancy, congenital virilization, IUGR, low gestational age, rapid growth in childhood, premature adrenarche, atypical puberty, and metabolic syndrome. In adolescence, epigenetic factors like hyperandrogenism, anovulation, polycystic ovaries, metabolic disorders, these all give rise to obesity. Now, what the epigenetic factors are? The genes are already there in the individual, but the behavioral and the environmental changes, they play a lot of role in expression, in the gene expression. These are the epigenetic, they are the epigenetic risk factors for PCOS. Now, genetically programmed hypersecretion of androgens from the ovary gives rise to insulin resistance, android obesity. Insulin resistance further gives rise to increased lipid storage, altered fat metabolism, hyperinsulinemia. Hyperinsulinemia further gives rise to altered steroid hormone metabolism, promotes LH binding to the receptors, increased IGF pathway of androgen production of the theca cells. That's how the PCOS present with acne, hirsutism, hyperandrogenism, infertility. I just would like to share with my clinical experience. A girl happens to visit in the clinic, and she is being told that she is, and she shared this thing with me, is madam, I have been told that I carry more male hormones than the female hormones. So that's how the explanation of PCOS is put across with hyperandrogenism. Now, etiopathogenesis of PCOS, genetics and epigenetics, these bring about the hormonal changes exacerbated by the obesity. Now, one lifestyle, they play a role in obesity, which brings about hyperandrogenism, insulin resistance, and a very low-grade inflammation. Hyperandrogenism works on clinically presents as hirsutism, acne, and in reproductive age group as oligo or anovulation, menstrual irregularity, subfertility. Insulin resistance gives rise to metabolic syndrome, impaired glucose tolerance, and type 2 diabetes, who are at increased risk of cardiovascular accidents. Psychological issues like body image, self-esteem, depression, and anxiety. This really shows the mechanism of polycystic ovary syndrome. The pituitary and hypothalamus, the pituitary gland increased LH and less of the FSH, which works on the ovaries, and these ovaries, due to the LH surge and LH increased LH secretion, they change to polycystic ovaries, which in turn increases the estrogen and AMH. At the same time, there is excess ovarian androgen, and these ovarian androgen work on the liver, which reduces the sex hormone binding globulin, and action on the sebaceous glands, which gives rise to hirsutism, alopecia, acne, and further the androgen also works on the adipose tissue. Evolution of PCOS summary: environmental factors, inositol deficiency, insulin signaling. This all triggers on the pituitary dysfunction, enhanced ovarian androgen production, and development of insulin resistance. This was the study done in 2017. Now, symptoms, their frequency in PCOS. Menstrual cycle disturbance happens in almost 70% of the individuals, oligomenorrhea 50%, amenorrhea 10%. Abnormal heavy, that happens in 10 to 15%, hyperandrogenism in 70%, acne, hirsutism, alopecia, acanthosis nigrans, obesity in almost 50 to 60%, and only 20% have normal menstruation. Infertility is seen in 70% of the women, but even if they conceive, they land up into pregnancy losses up to 60%. Cosmetic concerns are mainly because of alopecia, and in the neck region, they have acanthosis nigrans. What are the tests needed to diagnose hyperandrogenism? The gold standard test is mainly the total testosterone, and if at all, 17-hydroxyprogesterone. Most of the time, total testosterone is more than enough to give us the complete information. 17-alpha-hydroxyprogesterone is done to rule out late onset congenital adrenal hyperplasia. The normal values of serum androgens over 100 is diagnostic of adult onset congenital adrenal hyperplasia. Total testosterone is normally 20 to 80. Anything above that is suggestive of PCOS hyperandrogenism. Now, the diagnostic criteria of PCO in adolescent 14 to 21 years, mainly adolescents, they present with hyperandrogenism, persistent elevation of total testosterone serum levels, hirsutism, moderate to severe acne, oligoanovulations, persistent oligomenorrhea for at least 2 years after menarche, primary amenorrhea by age of 16 years, and complete pubertal development. The volume, the ovarian volume is more than 12 cubic centimeter. Now, an advanced age, well-documented long-term effects of hyperandrogenism are seen. At the same time, in long-term menstrual history of oligomenorrhea is seen. Now, ultrasonography, many a times polycystic morphology, what it says, it should not be used for the diagnosis of PCO in those with gynecological age of less than 8. Gynecological age is measured from the time of menarche. Now, a girl presents with multiple cysts, they are labeled as multifollicular ovaries in this life stage. So, number of follicles more than 20 and ovarian volume more than 10. That is the gold standard for the pelvic ultrasound to diagnose polycystic ovarian morphology. Now, clear protocols are recommended for reporting follicle number per ovary, ovarian volume, and ultrasound. Recommended minimum reporting standards include last menstrual period, transducer bandwidth, frequency, approach, number of the follicles, 2 to 9 millimeter, 3 dimensions, reporting of endometrial thickness and appearance preferred, 3-layer endometrial assessment, and at the same time, UC for the volume of the ovary. There are different other modalities, ultrasound, 3D ultrasound, and sono AVC, where we count on which the machine is semi-automatic and gives the count of the number of follicles. Antimalarial hormone, does it give any, is it a marker for PCOS? In AMH is basically related to the fertility. It is if there is increased AMH. So what it says is serum AMH levels should not yet be used as an alternative for detection of PCOS as a single test for diagnosis of PCOS. Now, there is an emerging evidence that with improved standardization and established cutoff levels or threshold based on large scale validation in population of different ages, AMH may become, assays will be more accurate in the detection of PCOS. Now, what are the complications? Why are we so concerned about the different effects of hyperandrogenism, insulin resistance, hyperinsulinemia, metabolic syndrome? How does it impact a woman's life? Infertility, primary infertility in almost 50% of the women, secondary infertility in 25% of the women. Obstetric history, it has impact almost as 3 times high risk of the preeclampsia, 3 times higher risk of GDM, gestational diabetes, and 2 times increase in fold of preterm deliveries, and risk factor for IUGRs. Cardiovascular, they are more at risk of myocardial infarction and arterial hypertension. Metabolic, there is increased risk of developing type 2 diabetes. Oncologic, they are, because of the unopposed effect of estrogen, they are more at the effect of, they are more at risk of endometrial cancer. Psychological, 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, reduced quality of life. Now, clinical features points to remember. Endometrial cancer is because of the endometrial stimulation with estrogens causing endometrial hyperplasia, thus increasing the risk of endometrial cancers. Now, hirsutism, excessive, it presents with excessive hair. Androgen receptors and androgen increase the growth rate. The hair is thick, coarse terminal hair in androgen-dependent areas point to an underlying hyperandrogenic state. There's a FG score which tells us in the body distribution of the hair. So any score between 6 to 8 is considered as significant. Acne, they present with different, those might be persistent up to 5 to 7 days, or they may become as comedones and lumpy nodules, which are tender, and premenstrual flare-up. So these are the different ways in which the acne may present. And acne lesions may also be present on the chest, shoulders, and back. Acanthosis and alopecia, typically thick, dark, velvety skin situated on the nape of the neck, axilla, groins, and frictional areas. So these are the signs of insulin resistance. We discussed about the hyperandrogenism and oligo or anovulation, metabolic and endocrine disorders. Now, how does it has impact on the adolescents with the insulin resistance, gives rise to obesity, hyperandrogenism, and premenopausal women. They also have incidence of infertility, hyperandrogenism, obesity, pre-diabetic, type 2 diabetes, hypertension, dyslipidemia. The metabolic incidence is very high and they are at risk. The risk factors for metabolic syndrome, central obesity, hypertension, atherogenic dyslipidemia, insulin resistance. Metabolic syndrome affects 33% of women with PCOS. Now, the metabolic syndrome results in cardiovascular diseases, type 2 diabetes, cancer, sleep apnea, and psychological problems. Screening for cardiovascular risk in PCOS. These include obesity, lack of physical activity, smoking, family history of type 2 diabetes, dyslipidemia, hypertension, type 2 diabetes mellitus, and impaired glucose tolerance test. How do we manage then these patients who have a plethora of symptoms? The patient-centered care by a multidisciplinary team may help reach the main goals of polycystic. Multidisciplinary team includes the lifestyle plan and support, treatment of hyperandrogenic symptoms, endometrial protection, contraception, fertility counseling, psychological and behavioral support, nutritional counseling, metabolic screening, and intervention. We divide PCOS into two groups who opt for pregnancy or ovulation induction is desired. If yes, then we have the first line of drug, clomiphene citrate, letrozole, and the second line is metformin, which works very good in insulin resistance. Lifestyle modification, of course, for obese women, obese PCOS, and in hirsutism, for them, electrolysis and light-based therapies are advised. For acne, topical creams are advised. And patients, women who do not want to have the childbearing time, for them, and ovulation, they usually come to us with a menstrual irregularity. For them, they want the periods to be regular, so they can be put on hormonal contraception. Even the patients presenting with heavy periods, levonorgestrel releasing intrauterine system, Mirena is given the option. Second line of treatment is metformin, insulin resistance, definitely metformin, obesity, lifestyle modification, hirsutism. We do have anti-androgen therapy, second line spironolactone and metformin. For acne, they can be put on different hormonal contraception, topical creams, tretinoin, and spironolactone. Now, these are the different group of patients depending on what is their requirement, whether they have come for acne, menstrual irregularity, heavy periods, or obesity, whatsoever. Many come with just complaints of that they are gaining weight and their periods are getting scanty. So the treatment or counseling is guided towards is customized as per the symptoms. Now here we are just treating the symptoms and not the cause. The hormonal imbalance giving rise to hyperandrogenism, LH-FSH imbalance, which further gives rise to amenorrhea, oligomenorrhea, anovulation, acne, impaired IGT, and obesity. Metabolic imbalance is progressing to insulin resistance and dyslipidemia. So the current armamentarium are the insulin sensitizers, anti-androgens, oral contraceptive pills, ovulation inducers, cosmetic, and others. So management of PCOS, the lifestyle management has to be the center stage. Now, lifestyle changes include the diet, exercise, weight loss, behavioral changes, smoking cessation. So this again becomes the clinician, dietitian, and exercise specialist, counselor. They form a multidisciplinary team approach. A 5% loss of body weight will reduce insulin resistance and circulating androgens, resulting in spontaneous ovulation and improvement of symptoms. Women with WHO Group 2 anovulatory infertility with PCOS who have BMI of 30 or over, weight loss alone may restore ovulation, improve response to ovulation induction agents, and have a positive impact on the pregnancy outcomes. Diet-wise, we need to counsel them about caloric deficit of 3,500 to 7,000 per week for weight loss. Spread the calories throughout the day by 5 to 6 small meals. Then foods with low glycemic index take longer time to digest, cause low and slow rise in blood glucose and insulin levels. Vegetables, legumes, fruits have low GI ratings. Refined carbohydrate to be avoided. Now the cholesterol intake as to butter, ghee, milk, cholesterol less than 300 milligrams per daily per use. Use low-fat cooking methods like baking, broiling, and grilling, boiling rather than frying. So all these changes need to be really brought into the lifestyle of the woman. Exercise frequency 5 days a week, intensity moderate, aerobic exercise almost about 30 minutes per day, 150 minutes per week, and start low, go slow with a moderate intensity. The activities could be cycling, swimming, walking, running, excuse me, skipping, hiking. So these are the activities we need to encourage. Treatment for weight reduction, diet, exercise, lifestyle modification, even 2 to 5%, that will reduce the testosterone by 21%, and they start with the ovulation in 50% of the women. Avoid alcohol, smoking, psychosocial stressors. Managing the menstrual disturbances. Now, these menstrual disturbances, if the woman does not want to receive medical therapies directed towards the interruption of the effect of the unopposed estrogen on the endometrium. Non-fluctuating levels of unopposed estradiol in the absence of progesterone causes irregular uterine bleeding, amenorrhea, infertility, and increased risk of endometrial cancer. OCPs elevate risk for the CVD. They cause dyslipidemia and increase chances of thromboembolic events. A low-dose oral contraceptive pill is therefore recommended for the menstrual regularization. For hirsutism, we do have spironolactone, cyproterone is the drug of choice, flutamide, finasteride, and mechanical methods, cosmetic, have shaving, plucking, waxing, delipatory creams, electrolysis, and laser hair reduction. These are the different modes for mode of treatment towards hirsutism. Treating anovulatory infertility, we have the medical method and the surgical. Medical methods, you have the first line is the clomiphene citrate, letrozole, and for insulin resistance, metformin is the second line. For surgical, for the clomiphene resistant women, primarily, this is the second line of treatment, that is a surgical ovarian drilling. And the first 6 cycles are ovulatory after the ovarian drilling. Studies have shown that ovarian drilling does not appear to improve the metabolic abnormalities in women with PCOS. Letrozole is used for ovulation induction. In PCOS, health professionals and women need to be aware that the risk of multiple pregnancy appears to be less with letrozole compared to clomiphene citrate. Now, the combination of clomiphene citrate and metformin, what does it say? Yes, clomiphene citrate, it induces ovulation in anovulatory infertility, and metformin could be used alone in women with PCOS with anovulatory infertility and no other infertility factors. Metformin is being used for ovulation induction in women with PCOS who are obese. Then CC, clomiphene citrate, could be added to improve ovulation. That's what the guideline says. Now, concerns about metformin. We should be careful while prescribing metformin. The gastrointestinal side effects are common, like nausea, vomiting. So start with lower doses and then slowly increase with 500 milligram over 2 weeks. And extended release preparation may minimize the side effects. Gonadotropins are used for ovulation induction. Gonadotropins could be used as second-line pharmacological agents in women with PCOS who have failed in the first-line ovulation induction therapy and are anovulatory and infertile with other infertility factors. So gonadotropins can be supplemented with the CC, letrozole, depending on the requirement, and these are the second-line pharmacological agents. CC gonadotropins can be supplemented with metformins, and even along with the after the ovarian drilling, gonadotropins can be supplemented. Now, laparoscopic ovarian surgery should be considered the second-line therapy for women with PCOS and who are CC resistant with anovulatory infertility. Now, inositol levels are found to be very low in PCOS patients compared to normal subjects. Inositol levels in PCOS subjects, they are like comparatively, they are pretty low, and the urinary inositol is high. When it was measured, then the urinary inositol was very high in PCOS. Now, the function of inositol is signal transmission of secondary messenger intracellular calcium, controlled maintenance of the cellular membrane potential and metabolic effects, serotonin activity modulation, nervous system regulation, and gene expression. Now, myoinositol has effect on various aspects of like insulin in the cellular, insulin uptake, glucose uptake in the cell is done by myoinositol, the combination of MI and DCI, and it also has impact on the FSH, calcium ions intake, intracellular transportation of the calcium, and at the same time steroidogenic modulation. There is myoinositol blocks the increased androgen production. At the same time, it again blocks the insulin resistance, and that's how myoinositol is so very important. The combination of myoinositol and chiroinositol is so very important. Oocyte evolution, oocyte maturity, and fertilization. These are the different things where calcium ions transportation is important. MIDCI in PCOS, it normalizes the insulin signaling and glucose metabolism, thus reduces the insulin resistance. It reduces the level of LH to physiological levels, and the fertility thereby restored. At the same time, it reduces the inflammation of ovarian theca cells, giving rise to lowering the levels of the estrogen to normal levels. So this is how the combination of 40:1 MI-DCI in PCO. Now, this again, a study shows myoinositol in the treatment of teenagers affected by PCOS. So that was the conclusion was administration of MI is safe and effective to prevent and correct metabolic disorders in teenagers. Combination of MI and OC pills. Anti-androgenic effects are enhanced and negative impact of OC pills is improved. Now, Indian clinical study, which was done in Apollo Hospital, Delhi, the supplementation of MI-DCI improved oligomenorrhea, and there was reduction in the incidence of acne, and the Ferriman-Galloway scores also reduced. So the study carried by study in by Dr. Tripti Nagaria, who's my teacher in Raipur, Chhattisgarh. They had done the study. So happy to present this study in 2017. Now, what the conclusion said, the present study confirms that myoinositol reduces insulin resistance and improves menstrual irregularities and PCOS cases. The combination of myoinositol and DCI again decreases the fasting insulins, and HOMA index was reduced, reduction in testosterone, significant increase in the serum sex hormone binding globulin, and insulin meta-analysis illustrates a firm evidence of MI. So, international consensus, what it demonstrates is the dose of 4 grams per day is to be prescribed. Now, the 4 pillars of PCOD management with MI and DCI per day 4 gram dose, and ratio has to be 40:1. Taste should be acceptable, and compliance should be good. Formulation could be tablets, capsules. These have a lower absorption, and that can alter the efficacy. Now, inflammatory markers in PCOS, circulatory inflammatory markers in PCOS, gut permeability, metabolic endotoxemia. This gives rise to increase in cytokines. Roles of pro-inflammatory cytokines causes phosphorylation of insulin receptors, protein leading to insulin resistance. In lean PCOS, the leaky gut causes increase in serum TNF and IL-6. The TNF-alpha and IL-6 have been linked to insulin resistance. Endotoxins, LPS in the systemic circulation leads to increased fasting glucose, insulin levels, and resistance. Human studies have provided that good gut microbiota improves insulin sensitivity. Now, dysbiosis of gut microbiota, how it has impact on the, what is this entity seen in PCOS? These women have increase in gut mucosal permeability. LPS from gram-negative bacteria enters into the systemic circulation. Immune system is activated, and this induces low-grade inflammation, which interferes with the insulin receptor function, increases insulin resistance, and there is increase in the ovarian production, androgen production. Alpha-lactalbumin. How alpha-lactalbumin works? It enhances the epithelial barrier. It increases the adhesion to the intestinal mucosa, inhibition of the pathogen adhesion, competitive exclusion of the pathogenic microorganisms, and then production of antimicroorganism substances. And that's how it allows the modulation of the immune system. So rebalances alpha-lactalbumin, rebalances gut dysbiosis, achieves eubiosis. Now, myoinositol and alpha-lactalbumin improves myoinositol absorption, peak plasma concentration of MI, and with MI, alpha-lactalbumin plus and MI alone. The combination and MI alone, when it was given, it was shown that association with ALAC significantly improves myoinositol absorption of MI. Now, effects of myoinositol plus alpha-lactalbumin in myoinositol resistant PCOS women. So this has a positive impact in spite of women who have been supplemented with myoinositol. They really do not show any changes in the PCOS symptoms. So in them, albumin supplementation does give you good results. It maximizes ovulation rates, almost 37 anovulatory women. When MI alone was given, only 62% was women showed ovulation, whereas the combination of MI with ALAC, 95% women ovulated. So 95% ovulation rate was seen in MI plus ALAC group. Reduction in hypoandrogenemia, which showed significant improvement in the sex hormone binding globulin. Now, experts' opinion in inositol in treating polycystic ovary syndrome and non-insulin dependent diabetes mellitus, the combination of MI and alpha-LA was found to be effective in PCOS. MI and alpha-LA safe at therapeutic doses. US FDA approved also. Now, objectives of assessing the quality of life in women with PCOS. These are the women where we should really spend some time to assess the quality of life and the impact of the symptoms, how it is impacting with her self-esteem and her psychological anxiousness, psychological symptoms she's going through. If these were shown to have, we need to have improve the communication with these patients, and then improve adherence to we should encourage them and pursue them about the importance of lifestyle changes and encourage them to be really adhering to the lifestyle changes which they need to out, and how important is the self-care to improve the quality of life. So PCOS manifests in women at reproductive age when issues such as finding a partner, initiating sex life, and forming a family are often very relevant. Factors that negatively affect physical appearance or femininity or compromise fertility are sources of great anxiety and can lead to imbalance in psychosexual sphere. Depression and anxiety are highly prevalent in women with PCOS, and is found to have fourfold increase in the prevalence of depressive symptoms in patients with the syndrome when compared to controls, even after adjustment for BMI. Daily fatigue, sleep disorders, changes in appetite, and loss of interest in everyday activities were the most common symptoms. Thus, the evaluation of quality of life in women with PCOS is essential for better care and clinical management of these patients. So, PCOS is a multifaceted condition, a multidisciplinary approach needed. Lifestyle modifications like diet, exercise, behavioral therapy are a principal treatment. Low-dose gonadotropins can be the first-line agents when affordability and accessibility are not the major issues. IVF ICSI indicated when previous interventions have failed in tubal occlusion or male factors. Thank you for patient hearing. Let us all join hands to face and treat this syndrome by multifaceted approach by all the endocrinologists, dermatologists, gynecologists, fertility specialists, and psychologists. With a multi-pronged approach, definitely we can tackle this syndrome in a much, much better way for a healthy lifestyle of the women. Thank you. Thank you so much.
Thank you, ma'am. It was a great learning and honor to hear you, ma'am. So, ma'am, if you allow me, then we will have a Q&A session.
Yeah.
Yes, ma'am. I'll read out the questions from the chat box.
Yes.
Dr. Sushil Gupta saying that it's a nice program.
Thank you.
Ma'am, we have one question that is, what is the approach for ovulation induction in a high BMI PCOS patient?
See, first thing, we have to encourage them for the obese PCO, what they come into the group of obese PCOD. In the outset only, I explained that about even if a loss of 5%, that will definitely reduce the testosterone by 21%, and that's how it encourages ovulation. So encourage her for lifestyle modification. In maybe about 6 to 4 weeks, you can encourage on that, and then you can start with the ovulation induction. That gives much better results.
Thank you, ma'am.
As the first line of ovulation induction is clomiphene citrate or letrozole. And for clomiphene citrate resistant, the second line comes is the metformin. That's how we can on ovulation induction for the fertility treatment.
Thank you, ma'am. We have one more question that is how to assess with ultrasound in PCOS.
Yeah. See, we need to make sure the width band is important, 8 megahertz. Then how do we see the number of cysts both ovaries we need to calculate. 2 to 9 millimeter cysts, 2 to 9 millimeter of the follicles are seen, and you have to measure the volume, ovarian volume more than 10 cc. Yes, of course, then they get into, and the picture is very, very, if you are doing the ultrasound, it is very clinically evident that and picked up very easily. You can just pick up on the screen that these are PCO ovaries, peripherally arranged multiple follicles are seen. And there is, at the same time, apart from the follicle, there is increased stroma. That also is an important thing I would like to share with my clinical experience as to the follicles measuring between 2 to 9 millimeter, about 20. Both the ovaries you need to count and sum up as about 20, volume about 10 centimeters, and there is increased stroma. This is the pelvic ultrasound finding.
Yeah, thank you, ma'am.
Welcome. I thank Shield Connect for having given me this opportunity to talk on such a interesting, which is very close to my heart. And as I was so impressed with the slide as to how much of importance is given to that we need to spend some time on the counseling and really give her a patient hearing as to what is her quality of life. And most of the time, when you keep on asking, her mother, the patient's woman, this is most commonly seen in the adolescent girls, and mother would be sitting there, and she would, the woman, the girl is really she's taken aback. No, she doesn't share, but mother tells us that most of the time she is not interested in her routine life. These are some of the mood changes, and the mother also doesn't realize that these are some of the psychological changes which the girl is going through, and all there's a lot of peer pressure, and sudden crops of acne and dark pigmentation around the neck. So this all definitely reduces her self-esteem. So that's a very good point. I would always like to share that we should really spend time with these young girls to pull them up and motivate them to take up the healthy lifestyle and improve in their diet quality.
Thank you, ma'am. You have pointed out the very good points that we have to focus on the quality of life and counseling the patients in a proper way. Yeah,
Of
thank you,
course.
ma'am. Ma'am,
Yeah.
I don't find any questions in the comment box. So if you allow me, then we'll
Okay.
close this webinar.
Definitely, we can close, ma'am.
Yeah. Thank you, ma'am. Thank you for giving us your valuable time and also giving us the very insights into the approach of PCOS. Thank you, ma'am.
Welcome.
And I thank all the delegates for joining today's webinar.
Thank you, doctor. Thank you
Thank you.
very much.
Welcome. I once again thank Shield Connect for having given me this opportunity. Thank you so much.
Yeah. Thank you, ma'am. Yeah. Many thanks from the Shield team. Thank you, ma'am.